All right, good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's webinar hosted by eMed Apps called ACOs of the Future, Team-Based Care Reimagined. And I'm really excited to hear from them today. They've got a lot of great ideas. Obviously, this is a lot on our minds right now as far as what the future holds with this crazy time that we've been in. So very eager to hear from them today. A few items of note before we get started. All attendees, including yourself, have joined the webinar today in listen-only mode, so you don't need to worry about muting your mic. That's been done for you. And I wanted to let you know that the webinar is being recorded so that you'll have the opportunity to rewatch the session and or share it with colleagues, and we hope that you do. I'm going to be sending after the webinar a link out to the recording as well as where you can download the slides. And so I will send you an email. You'll get that from me later on today with those links. And finally, during the webinar, we want to hear from you. So we would like you to submit questions if you have them. And the way that you'll do that is there will be there is a module, an attendee module, and there's a little question area. And you can submit the questions there. You don't have to wait till the end. You can submit them at any time. But we will get to as many of those as we can during the Q&A session at the end. If we can't get to yours, we will make sure to answer it via email afterwards. So go ahead and continue to ask it. Again, we would love to hear from you. All right, without further ado, I wanted to at this time actually turn it over to Jeanette Kebasic, who is the Business Development Manager at eMed Apps, and then she's going to introduce our speakers for today. So welcome, Jeanette.
Thanks, Garrett, and thanks everyone so much for joining us today. Ed and Vic have put together a great program, so let me introduce everyone to today's presenters and tell you just a little bit about the companies they're with. So both Vic and I, Vic Shashadri and I, are from eMed Apps. eMed Apps is a healthcare information technology services company. We work with a variety of healthcare clients across the U.S., and we offer a full range of services as well as a suite of products. Vic Shashadri is the VP of Product Management and leads all our product development initiatives for eMed Apps. He's also the chief architect of our care connectivity platform and has been the lead architect on interoperability projects with various clients, including IPAs, ACOs, payers, and HIEs. With his extensive experience and knowledge, Vic and his team have created innovative solutions to address some of the toughest challenges facing healthcare communities. Our second speaker today is from Northern Physicians Organization, also called NPO. And NPO is one of Michigan's largest physicians organizations. They own both a clinically integrated network and an ACO. Ed Worthington is the director of IT at NPO, and he spearheaded their successful health information exchange, interoperability initiatives, and security efforts. Prior to his tenure at NPO, he spent 9 years working in a variety of capacities as regional health at a regional health system. Ed led the technical IT project management and solution development for the Northern Region SHEER initiative, and that project was conducted under CMS's state innovation model. As a speaker, he's presented topics related to analytics implementations, health information exchanges, and payer reporting. With that, let me turn things over to Vic to open our program with the state of data exchange today.
Thanks, Jeanette. So I thought we could set the backdrop into our discussion this afternoon by kind of looking at where we are in terms of exchanging data between organizations for clinical care. And I thought I'd start with a highly technical schematic of what that might feel like to most users today as they're dealing with data exchange. So here we have basically a hodgepodge of different things that are put together to try to achieve that purpose. So that's kind of the backdrop that we encountered when we started this process of trying to figure out how can we use technology to take ACOs to where they need to be in the future. And so to that regard, as we kind of go through this, I'm going to set the stage here again with an actual client story. So an ACO that we got involved with to try to alleviate some of the concerns and some of the problems that we were seeing with interoperability and data exchange as it kind of sat and what was available to them in the environments that they were dealing with. So some numbers about the background to kind of set your thoughts as we kind of go through this whole presentation here. It is a physician organization, a community-based physician organization, I should say, comprised of both PCPs as well as specialists. One of the interesting aspects of this organization, and I'm sure is common among things that ACOs encounter all throughout the country, is it is not a single vendor dominated environment. There are a number of community-based physician groups that participate in this organization, and they use different EHR systems. Altogether, the members of this organization use a total of 6 different EHR vendors in terms of the systems that they're using in their clinics. On top of that, we have other sources of data in the community, being things like hospitals, inpatient facilities, skilled nursing facilities, and other organizations that see the same patient population that the ACO is responsible for. And so altogether, there are around 245 sources of data that are providing information, and that includes the 33 physician practices that are part of that physician organization. Within those practices themselves, we've got a number of users that are utilizing the technology that we put together here, from the physicians themselves, 74 providers, as well as the clinical support staff and the care coordinators at these organizations that are using the system to try to bridge those data gaps that we were talking about. We also integrated patients into the solution, and so there are over 16,000 patients that are actively participating in the system and are able to participate and manage information, as you'll see as we kind of go through this discussion. And then kind of to talk about the volume, to date, we've exchanged over 2 million CCDAs between these organizations and from some of those source environments that we were talking about earlier. So why did we kind of partake in this process of data integration and creating a solution that would meet the needs of this ACO? It started with an examination of what was already available, and the big player in this space, as I'm sure most of you are aware, are health information exchanges. So depending on your geographical location, you may be able to leverage an HIE to try to get some of this aggregated information available to you. In some places, the HIE just isn't present, and so you're kind of left with nothing. But even in the environments where you have that HIE, definitely some of the benefits that you see is that you have single access to a lot of data, right? Those HIEs are aggregating information from a number of places, and you can access that information from a single location. From the physician level, it meets all of sort of the criterias that I need to for data exchange by going through the HIE and integrating with them and interacting with them. One of the cons that we ran into and kind of talking this through with the ACO is the ability for the clinics to actually use that data in a way that kind of worked within their workflow. A lot of the HIEs require that you query for information from the HIE, or you go into the HIE and you search for information from there. But either way, the workflow gets disrupted for the organizations that were there. So we wanted to look at a way to use the existing workflow to augment the workflow with technology to really get to where we wanted to be. And that's kind of the mantra we took when we went through this process. We started with the existing workflow in the clinic organizations, and what kind of technology solution can we adapt around that workflow to get to the outcome that we're after. And so to talk about that in a little more detail, I'm going to hand it off to Ed.
Thank you, Vic. So yeah, like Vic talked about, we didn't just look at the technology and what kind of technology to implement there. We really spent a lot of time on the ground with the providers and all the different staff at the practice, trying to figure out and learn how they work with and interact with data. So not, when they access data, when in their workflow do they need data, and then probably more importantly, from a solution design standpoint, we looked at how they compensate when there's missing data. So if they don't have information on a patient that's coming in, what kind of steps do they take to try to mitigate that loss of information? And after putting that together and modeling that across a variety of practices, both primary care, specialty, urgent care, small practices, large practices, we then really came about and designed a technology solution that fits within their workflow and allows them to kind of optimize their existing workflow, but also fills in the gaps for information so that they can be more efficient. And what we want to do here in the rest of this talk is to go through this by different roles within a practice. Not all of them, but we wanted to identify care managers, providers, and patients. So I'm going to go to the next slide. And now, here we go. So I think everyone that's involved in some capacity with an ACO is well aware of the fact that care coordination, care management is an absolute necessity. And if it's designed well, it's implemented well, and the information is there when people need it for handoffs and to intervene, it helps the patients, the providers, and then as well as the payers with better utilization of resources and better quality outcomes. Next slide. And so some specific care coordination activities that we looked at when designing our solution with the practices and with the organization was communication and how they shared knowledge and information, how they handled transitions of care, how they retrieved, accessed patient goals and the needs of the patients, how they went about developing and sharing proactive care plans to avoid preventable outcomes, what steps they took to monitor the patient and to communicate with the patient, and how they linked that patient and integrated themselves with a variety of community resources to be a more effective resource for their patients. Next slide. From a technology standpoint, we identified a few areas that were pretty consistent in presenting challenges for care managers. One area was just around handling the whole concept and the mechanics around consent for data sharing. I think a lot of us are familiar with a variety of different consent rules, state by state, different rules for maybe behavioral health information, substance abuse information, et cetera. There's no standard consent. In a lot of areas, implicit consent doesn't work. It's very difficult to track and update consents and for the patient to possess meaningful agency over their consent and data sharing. And just aligning consents with a variety of data sources can itself be a challenge. Next slide. Another area was we identified was having complete data and how to get that data, either receive it or to transmit it to someone else. Some areas that we would, we commonly encountered as questions was, did somebody actually see a provider that a referral was made for? And they just didn't get a note back, or did the patient never go there? Did they end up going to a different provider? Where did they go? When? These kinds of questions can cause, create gaps in data and make care managers less effective in their job. To show how we resolved some of these challenges and to see it from a care manager's perspective, I'm going to turn it back over to Vic, and he's going to show a demo from the system of this area.
Great, thanks, Ed. So I'm going to jump over to the actual application here. Our community health cloud solution is what we put together for these organizations to be able to address the needs as Ed has started talking about. It provides users, whether those be the clinical staff, the care managers, or the providers themselves or patients, as we're going to talk about, to be able to access and interact with information in a way that makes sense for their roles. Users are presented with a branded website where they're able to come in, get to information, use things that's pertinent to them. I'm going to go ahead and log in here as a care manager. And when I do that, it takes me into what we call our notification display, or the items that need to be addressed by me. So one of the areas in sort of the workflow discussion that we came across is we don't want our care managers to go looking for information. We want that information that's pertinent to them, that's important to them, to be presented to them in a meaningful way where they can just look at that data, they can take action on that data and deal with the information that's being presented. And so that's what this notification queue does. It's comprised of notifications that are both automatic and manually generated. So the automatic notifications are things like patient scheduled appointments. So if the patient has appointments with any member of the care team, the other members of the care team are notified of those appointments. It could be things like notifications from inpatient and skilled nursing facilities. ER visits, inpatient visits, things of that nature that occur with your patients. Those notifications appear in real time to the care coordinator, so they're apprised of that situation. It could be notifications that are sent from one member of the care team to another. So a lab result comes in the primary care's office, and they think this is something that the cardiologist should be aware of. They can send a notification around that specific element of data to the cardiology group so they can be aware of that information as well. And so the intent is that this notification is sort of your work list from a care coordinator point of view. These are the items that need to be addressed by you. These are the items that are of interest to you that need to be addressed. It is sorted date sensitive, so the more important, the date information is going to be available, so you know what's pending, what's been sitting in there the longest that needs to be addressed. From these notifications, you can do a number of things, including sending this to other providers, taking actions on the notifications, contacting the patient, things of that nature, and recording those interactions with the patient. The other ability that you have from this notification information is to dive right into the clinical data. So if I take one of my sample patients here, I can dive right into their clinical data, which is basically aggregated information across the different organizations within the community. So I'm going to be able to see things like all of the CCDAs that have come in. I can just look at the sort of the meta information about those CCDAs. What appointments does this patient have scheduled? We look at visit metrics. How many inpatient visits have they had in the last 6 months or a year? How many ER visits have they had? I can look at members of their care team that are external to my clinic. And then I can dive into individual data elements and look at aggregated data across my organizations here. So I'm just going to pull up an example here to give you an idea of what that looks like. I'm going to pull up the results section so I can look at aggregated lab information. And one of the benefits of having this solution is we're grabbing this data from multiple different sources. So it doesn't matter if that lab was done at the cardiologist's office, at the PCP's office, it was drawn during an ER visit, or maybe I had a lab work scheduled and I went into the hospital for a reference lab draw and had lab work done there. All of that data is aggregated and I get insight across all of that data from one location. So I can look at specific lab data from a given visit in this case, and then I can go in and trend lab data across multiple visits. So if I want to look at this particular test across multiple different data sources, I can do that and see that information and see what's going on with this patient with regard to that. So if I jump back to our slide deck here, so what are sort of some of the benefits that that we're seeing from that? With that actionable data, the patients themselves are presented to the care team in a default notification view that's their focus for the day, right? So they're not going and looking for data. They see the information that they need to access and what they need to do with it. We provide the ability to filter that data, which I didn't really go into much detail on, so that I can create default views for different roles and different things that I do in my normal day-to-day activity. So I can just quickly change tabs and look at different views of that data based on what I'm processing. So maybe right now I'm interested in looking only at emergency room visits that occurred for my patient population. So I can create a default filter on the notification data to look at only ER visits. And so I'm focused then only on that information, and I'm able to see that. I'm able to trend data across multiple data sources, so I can get a true picture of what's going on with this patient. I can look at that admit and discharge information across facilities as it comes in real time and is available to me in my notification view. So here's how our care managers are benefiting from using this. Number one is that consent workflow, which we'll talk about a little bit more, becomes a patient engagement opportunity. We're bringing the patients into their own care as part of their care team. They're a critical component of that care team, and to bring them in and to have them interact with the system and to participate in that care process is really a great benefit to these care managers. The second benefit that we've seen is that the care managers are able to practice at the top of their license. They're not spending time looking for information, trying to aggregate data together, trying to put the pieces of the puzzle together. They're looking at the puzzle completed and trying to then take action on that. So they're spending their time in ways that are leading to better benefits for the patient. Because all of this is real time, they're able to identify gaps in care without having to wait till that next visit. As this information comes in, that data is available to them. They're seeing it pop up in their notification screen when it's things that they need to take action on. And they're not having to wait till the patient presents the next time and they do a chart prep or something of that nature, and they're able to then go in and deal with that at that time. Ed, I'm going to hand it back to you to talk about providers.
All right, next slide, please. So as we did with the care managers, we spent a lot of time with a variety of different providers. Like I said earlier, specialists, urgent care doctors, small practice providers, larger practice providers, and really worked with them and listened to them about a lot of the challenges they have around workflows and data, and how it can both make them more efficient if they had what they needed when they needed it, and two, how existing challenges, like many of the ones Vic talked about earlier, make it more difficult for them to provide the best care possible for their patients. So some of the challenges that they had were inadequate information about tests and procedures, difficulty, especially with a variety of different results. So sometimes they get results from, let's say, like a VA lab, and it comes in and it's faxed to them instead of interface, unless they have a clerical person that takes time or like an MA or someone that takes time out of their schedule to chart those discreetly if their EMR allows it. They can't really trend and look at results across the board for a patient that might receive care for a chronic condition from a variety of sources. Another area where that's a challenge is if they go to, let's say, like an endocrinologist that does labs within their practice, they might just get a result tucked back somewhere in a progress note. Patient matching in multiple sources of data. Patient matching is a challenge throughout, I think, the healthcare kind of integration ecosystem, how best to do it, how to reduce errors, especially as you expand the number of data sources. And then the inability of a lot of EMRs to really meaningfully import a lot of data. That creates a huge challenge for providers who would rather, I think all of us would agree, stay within as few tools as possible to make them more efficient, because there's always some loss of efficiency if you have to switch back and forth between tools. Cumbersome communication, really easily communicating and tracking that communication within the context of a patient is a challenge, with existing tools. You can send a direct message if you know the person's direct message, direct trust account, and they're in the bundle. There's some external texting solutions, but they're not really context specific. Phone calls take a lot of time and are very disjointed. Somebody has to stop seeing a patient to answer the phone, or people play phone tag for a while, which just delays the exchange of information. and the lack of information provided for available social services, and then also just handling communication for patients that might receive care out of their area if they live, let's say, in a northern climate and they go to, let's say, Florida or Arizona for part of the year, and they have a care team down there as well. And receiving data in a timely fashion. So, you know, if a patient's discharged from the hospital, getting that information before the patient comes in for a visit, ideally as quickly as possible so that a med rec can take place, and so that they can get the patient in within a few days, and they're not as reliant on the patient remembering what happened and trying to work from there. So to go through again, like we did with care managers, I'm going to pass the control back to Vic, and he's going to demonstrate how we resolve some of these challenges within the provider workflow.
Great, thanks, Ed. I'm going to jump back into our Community Health Cloud, and now I'm going to log in as a provider into the system. Based on the role that you're accessing the system with, your interaction with the system changes. In this case, as a provider, I'm looking at my notifications in a slightly different way. The community is able to decide, or the organizations are able to decide how notifications are routed. So, for example, in this scenario, providers aren't getting any of the appointment notifications. They don't know at a detail level every appointment that's made by the patient in the organization. That's handled by the care managers. But they are getting notifications about hospitalizations and things of that nature. So in this case, I'm looking at those hospitalizations, at the admissions and discharges that have occurred for my patients. So they're able to then interact with this data similar to the care managers, and they're able to take actions based on the information that's coming in. They can notify their care managers if they want them to take action in some way. They can communicate with other members of the care team in order to be able to send information to them. They also have access to the consolidated record, and we offer that in one of two different views. I showed you sort of the longitudinal view when we looked at the care managers, and what I'm going to show you now is our timeline-based view of the patient data. So this gives the providers an opportunity to look at the data for that patient across a timeline. By default, it looks at the last 3 months worth of data for this patient, but I have the ability to go in and change that to other different timescales that may be appropriate for me. When I do that, what it's going to do is it's going to provide me a visual representation of all of the different interactions this patient has had. So I can see when their hospitalizations have occurred. I can see what kind of lab data is available, medication and allergy information is available on this patient graphically. I can interact with the timeline. If I want to zoom in on a particular time period, I can do that and look at what happened during that time for the patient in question. I can click on a given item and look at details. So in here I can see that there were 2 medications prescribed on March 10th of 2016, and I can see what those medications are. I can see the statuses of those medications. I have the ability to generate notifications from there. So if this is something that I want to notify another or member of the care team about, I can do that. I can do it based on the care team members themselves, or I can go in and assign it to specific groups, the notification, and then I can come in here and I can create a message around it. What's of interest to me? Why do I want this other member of the care team to look at this particular element of data that's present? And when I do that, I can then bring that to their attention. So it's going to show up in their queue and they're able to deal with it and address that information as well. So with bringing the providers onto this environment, what are some of the benefits that our providers are seeing? It becomes an optimal delivery of care, right? There's a holistic view of the patient data. They're getting aggregated information in this community-based environment. Their patients are seeing multiple providers. They're going to different organizations, and the provider is able to see all of that information at the point of care. They get actionable insight from that data at the point of care. It definitely helps with the chronic management. You get the unified record. The care coordinators are able to see that unified information, and as a result, you get better chronic care management for your patient. It also streamlines the provider's process. They're not having to go look for this information. It's not being presented to them in multiple different areas. that they need to address. So their prep time in dealing with patients can be reduced as well, which can have a positive impact on the revenue as they're able to see more patients without having to spend time around these areas. Ed, I'm going to hand it back to you so you can walk us through patients.
All right, thank you. Next slide, please. So as we did with the providers and care managers, we did meet with patients as well. I remember one notable time was a larger primary care practice actually had a patient council within their practice of about 10 or 15 patients that were a cross-section of the population. And we had the pleasure of sitting down with them a few times and talking to them about our tool, our solution, and some of their fears around data sharing and concerns, and some of their what they need and what they'd like to see. And some of the things we found was they're often unclear about why they're being referred to specialists, about how to make appointments. What's that? There's some patient-centered medical homes, for instance, that'll do the appointment and handle those logistics for the patient. Sometimes it's up to the patient. Sometimes it's up to the specialist calling the patient after referrals made. And then what to do afterwards. They had this appointment. What's the next step in their care? Do they go back to their primary care? Do they just follow the specialist? They're looking for help with that coordination and integration of all their care. They struggle to collect their medical records. Sometimes for very ill people, that falls on family members. And we know if there's less information and information that's critical is lost, less efficient care is going to be provided, things might be repeated, mistakes may be made. And this is all especially crucial for the 15 to 20% of patients that are probably make up the largest chunk of the effort and cost within an ACO. Because for those people, and those individuals, a lot of people might think that portals, there's your great solution. You have a portal, you go get it, information. But if you see a lot of patients, or a lot of providers, I should say, maybe 3, 4, 5, including specialists, and you have a relationship with a hospital because you get some testing done there, or you split your time between 2 different places, portals become almost counterproductive because you have too many of them. It's too many logins to remember for a lot of people, too much logistics. Where do you go from here to there? How do you get that information back and forth? If you only see one provider, it's a great tool, but it doesn't necessarily work once you have to coordinate between a lot of different providers and care settings. And then also the challenge of when should I contact my provider? Patients may not know when they need to contact their provider for proactive care or a follow-up. Is it after a test? Do they wait for a contact back? Sometimes they just don't have that information in those cues to make those decisions and to take those actions. So to show you kind of our patient section, which we have in this system as well, I'm going to turn it back to Vic, and he's going to provide a demo of that.
Great, thanks, Ed. So once again, I'm going to log back into the cloud, but this time as a patient. And so I'm going to get a patient-centric view here of the information. Looks like I forgot to put my password in, so that would help. And the first thing that I'm greeted with when I log in here is my consent information. So the way this functions in the Community Health Cloud is the patient manages the consent across all the different sources of data that are present for that patient. So when I log in, I'm going to see a list of all the different sources of data that I have. So where have I been as a patient that has generated information for me to look at? From the source of data, I have the ability to determine whether my care team can view that data or they're unable to view that data from that source. And so then the cloud handles the rest in terms of building the views that are available and the aggregate clinical displays that are available based on that patient consent. The patient has the ability to define a default consent. So they can then define and say, as new sources of data are present and pushing information into the cloud, what is the default action that I want to have take place here? Do I want to allow that information to be seen or not have it to be seen? So the patient can define this default consent, and then the system will use that default consent as data becomes available. At any time, if the patient decides to override that default consent, they have the ability to do so by coming in here at a organization level and changing the consent associated with that organization. On top of the consent management process, the patient has access to all of their data as well. They're able to go into their clinical data tab and view the same timeline and longitudinal based views that the clinical care team and the providers are looking at. The difference, of course, for the patient is it is aggregated across all sources of data, regardless of consent, because they're the gatekeeper. They're looking at everything. So they can see those same lab results that my care team was looking at. They can go in and look at that same timeline view that my provider was looking at and see the same information that's available there for them in the timeline view. And then the other benefit that the patients have using the cloud is they're able to see what's going on with their data. They can actually come in here and look at the actual data access history. Who's doing what with my information? So all the data that we looked at today has been logged in here, and the patient's available to see that these different users have gone in and looked at my information in the system, and they're able to see what's happening with their data. So they become the stewards of their own data. They become involved in the same process with the care team. So how does that benefit the patients? So number one is it improves the communication. They're not trying to retell the same story to providers over and over again. The provider has access to that story before they even see the patient. They're able to see that information. They're able to digest that information, and then they're able to communicate with the patient with some knowledge about that patient and their history. They're able to control the access to those records themselves. They don't have to call into the clinic and have the clinic make any changes. They can go in, log into the portal themselves. They're able to manage that consent. They're able to change that consent based on whatever they need to do. With the whole community health cloud solution, with improved chronic care management, with proactive care, patients can avoid hospitalizations and ER visits, leading to better quality of life and better outcomes for them, which definitely has a positive impact on the patient. So I'm going to hand it back to Ed now to talk about how this sort of patient-centric cloud model and what the future of ACOs hold.
Okay, great. Thank you, Vic. Next slide. So there's some metrics we found. I know they're between 2010 and 2018. I think one thing we could see is that there's a marked increase in the number of physician group-led ACOs, which seem to be slowly, and if this trend continues, maybe even forming a majority of the ACO market. Whereas, in the beginning, there were more joint-led ACOs that might have, and that may have been more because of needing hospital resources or system resources for capitalization, but we're seeing now physicians taking the lead more, which creates some different challenges and opportunities within the market for, I think, physicians to make some changes in healthcare information sharing to provide better care for patients. Vic, if you could go to the next slide, please. I think we saw that health systems or health system-backed ACOs were definitely dominant in the beginning. But now with the physician groups taking the lead more and more, we see some different advantages and challenges as well. One advantage is that there may be more of a emphasis on eliminating hospital admissions. One thing being is that there isn't as concern about a potential loss of a revenue stream if it's a group of independent physicians starting an ACO as opposed to one that's maybe hospital-led. Not to say that hospitals weren't looking to reduce admissions, but there's definitely a different calculation from a financial perspective that has to take place when a hospital system is let's say, running a ACO. And making those more aggressive changes and looking at readmissions and admissions as a stronger metric for success, it would increase the savings and the financial benefits to the physician group-led ones much more. I think what we see as a challenge for physician group ACOs or physician-led ACOs is that there may not be as much capital and infrastructure that already exists from a technology standpoint and from a care management standpoint to affect those changes early on. Next slide, please. And Gallup actually provided an interesting graphic here. We wanted to share that about the 5 forces that are changing healthcare. I think we all know with COVID and everything, virtual healthcare got a shot in the arm and is probably here to stay in some capacity. I know we've seen the numbers trail off since March, April, but I think a lot of people that maybe were not as eager to embrace it had to embrace it out of necessity and became more comfortable with it. Mergers are a constant force in healthcare. I think different and unique ways of managing them we're going to see take place, and maybe more physician leadership, more of a stronger collaboration between maybe independent providers and hospital systems to try to be more effective. Maximizing the value of the ecosystem. I think from an information standpoint, it's really how to use this information, which is really in many respects a currency or a tool of value in healthcare to really achieve those outcomes that everyone's looking for. I think we all are hearing and have been hearing for years about value-based care, and we're starting to see more and more unique programs coming out of Medicare and different programs targeting maybe certain chronic diseases or more primary care focused ones. And I think the last one is a really good point. At least for the time being, we're all going to have to adjust to being constantly disrupted and constant changes. While I think all these changes in the healthcare system work themselves out. Next slide. But this creates a lot of opportunities for ACOs. And especially with using a tool like Community Health Cloud that we've been demoing and talking about here. When you look at a physician group or a physician-led ACO, it probably combines, maybe primary care and specialist providers, independent businesses essentially. A tool like this that provides that same level of efficiency that from an information standpoint that a hospital would have, being, let's say, entirely on Epic or entirely on Cerner. This tool provides that same level of communication for them without having to go through the cost, both monetarily and in lost productivity and training and everything, trying to get everybody on 1 or 2 different EHRs, which is a challenge and is not always successful, at least from my experience. It can improve the speed of collaboration, not just between providers and PCPs and specialists, but as we're all looking to engage parties outside of what we consider traditional healthcare. Whether it's like area agencies on aging for those patients that are maybe dual eligible and receiving home care and trying to keep them out of the hospital, or patients in PACE programs, or even just social services for someone that has is not being able to get their meds or go to their appointments because they have transportation issues. A tool like this can help retain staff. They're not going to get as burned out as much, spending lots and lots of time doing what effectively is clerical work below their level of training, but just try to find the information to do the work that they were hired to do. And we believe that these tools and tools like this and better information management that's tied to their workflow, that sits within that works with them throughout the day, isn't something that they have to go out to necessarily, will increase their opportunities for shared savings and quality improvement. And then also just improve the general experience for patients and providers and other caregiving parties to the patient. Next slide. And if we look at it, a tool like Community Health Cloud provides a lot of different features to make sure that you have all the data that you need at the point of care, rather than getting it over time, so that when a provider is with a patient, they can look at that information. When a care manager, let's say, is calling a patient, they have all the information in one spot, like Vic was showing. It works regardless of the practice size. We have single provider practices with just maybe 2 or 3 employees total, up to 10, 15, 20 plus provider practices with 50 to 70 employees. Regardless of the EHR system, we've been able to connect them. We've used APIs and FHIR where it's available. We've used more traditional interfaces, and we're providing comprehensive data in here. This is more or less the complete patient record, their appointment history, which differentiates it from a lot of health information exchanges where you have to go out and search for a patient. Hopefully they have the information that you need. Instead, you're logging in, if you're a provider especially, and you're seeing the schedule for the day. So you can go right to that next patient, when you're going to see that patient. It provides data from other important care settings like home health, skilled nursing facilities, behavioral health services. It can integrate social determinants. Paramedic data can be, service data can be implemented if needed. And a lot of this data is provided in real time. So with the client that we talked about at the beginning, they get real-time ADTs, real-time patient appointments, and the messaging with the clinical data that Vic showed is transferred to the recipient in real time. Next slide. And so some of our other key features that we wanted to highlight and that we showed throughout the demo was that one big thing is that the patient is in control and is the steward of their data, and they can manage their consent meaningfully. They don't have to call someone or go through a whole difficult process and fill out paper forms or anything like that. They're more comfortable sharing information, at least in our discussions with them, like I talked about before Vic did the patient demo, because they have that control right there. And it makes them more willing to consent to share information that they may be more conscious about, like let's say behavioral health information, because they can watch and police that usage, and they can revoke that consent if they feel like their privacy is being violated unnecessarily. It also eliminates the need for patient searches. I was actually a big irritant when we talked to a lot of providers and a lot of other staff users, is that, if you think about it throughout the course of a day, having to go out to another system, look up a patient, let's say the last name Smith, and finding the right, person, right first name, right date of birth, and then clicking on it and then going into the record, that adds up over the course of a day and a week. So eliminating that need by presenting the schedule for many common use cases saves a lot more time than even we thought in the beginning. The real-time aggregated data from all the practices displayed, like Vic showed, in a timeline or in a traditional chart format, allows users, based on how they like to interact with data, to view the data and work with it. They don't have to conform themselves to a specific workflow. And sending the messages attached to the data, one, just being able to click within the context of a chart and send a message saves a lot of time from having to repeat what's in the data. You're sending that data with the message. And it allows for quicker communication, quicker follow-up. Let's say a practice needs to talk to a pharmacy care manager about a medication. They can just send that right away. The pharmacy care manager can see the information and respond back immediately. And ADT notifications for anyone that uses them, regardless of the system, I think has seen the value of them. When it comes to hospital usage, ER usage, but also seeing them with appointments outside of your practice has been powerful, because that's a way for them to proactively see if referrals are being followed up on. So if they tell a patient that, we're going to send a referral to the cardiologist, you need to make that appointment, they can see that appointment was made and the patient canceled it, or that the patient rescheduled it, or that the patient did go, and then to expect information back or to request information. Next slide. And I think when we really looked at this and we talked with the providers and the ACO physician organization and other parties, we put together this kind of three-step process or three steps that really we think made a meaningful change in the workflow throughout the entire organization. By starting at the bottom of, let's say, at the practice level, patient provider level, and patient staff level, automating processes that were manual now, we freed up a lot of time for people to work more efficiently, and it allowed for reduced test duplication, more timely access to information, and more accurate care by the providers. And all of this being stored in one system that's easily accessible, improved the efficiency for care managers and care coordination in general, especially when you accompany it with the messaging and the real-time ADT and appointments across practices. And what it really led to was improved patient outcomes and greater shared savings. So what we wanted to do with this tool, by focusing on the workflow and focusing on, working with the practices and building up, was that a lot of ACO tools, and for very good reason, work with, from an analytics perspective, they start globally. We're tracking quality, we're tracking cost, but they're not necessarily providing discrete improvements in the workflow needed to meaningfully impact those metrics. So you're seeing how you're doing, and if you're not doing well, you're just, you're looking at, oh, retrospectively, we haven't been doing well, but it's not providing you necessarily with the tools and the action to make those changes so that your numbers improve or your metrics improve. And that's what we did with Community Health Cloud, is we focused on that area, that need, and built a tool that provided that targeted efficiency improvement so that when they're working with analytics and metrics at the ACO level, and the providers are looking at the results from their performance here, they can see how their changes led to improvements, not only in quality and outcomes, but in shared savings throughout the entire organization. Next slide. Thank you.
So Garrett, we'll hand it back to you for the question session.
All right. Well, thank you guys so much for that. That was a very informative discussion. And we actually do have some questions that came through. And so we'll go through these. And I actually just posted something in the chat to everyone, which I'll get back to in just a moment afterwards. But let's dive into the questions here. So our first question is, our organization currently has patients opt out for consent. Would we still be able to utilize CHC since your model has patients controlling the consent process?
I guess I can go ahead and grab that one, Ed. Yeah, you can define a default consent for the patients, and then the patients then have the ability to go in and change that default. So if you are following an opt-out model, in which case your default consent is for the patients to opt in, then that can be defined, and that applies to the sources of data. And then as the patient logs into the cloud, they're able to then go in and make changes there as they see fit.
Okay, great. Second question is, we have our hospital and physician practices using the same instance of EHR. Is there any advantages that CHC could offer to organizations using the same EHR platform?
Yeah, I can tackle that. I think so. And one thing I think that within a hospital ACO that I think everyone's cognizant of, but maybe doesn't come about in a day, workflow, is that, even if that patient's attributed to your ACO, let's say, and they're largely seeing providers in that system, you have a not insignificant number of patients that are seeing providers outside of your ACO, or are living somewhere else part of the year, or getting care elsewhere. They've gone to other hospitals, and you're probably tracking this maybe through leakage reports. But having access to that real-time information via ADTs or scheduling and clinical information from those outside providers, or those outside community members like skilled nursing facilities or home care or community agencies that are providing interventions, social determinant interventions, are really powerful. And that really would complement some of the efficiency that exists that you may already have by having all of your ACO, official ACO providers within one health system EHR.
Great. All right, moving along. Next question is, does the view remain the same in tablets as well as in laptops?
Yeah, I can grab that one. It is designed to be accessed from multiple different devices. So in the example that we provided, the organizations are using tablets to interact with the cloud for the processes of patient registration and consent with the patient. So they actually have a tablet. When the patient presents, they register the patient through the tablet, and then they hand the tablet over to the patient, where the patient can select their password and things like that. And the patient will then answer the consent questions and then hand the tablet back to the clinical staff there. So the tool is designed to work on multiple different device formats.
Great. Next question is kind of a two-part question. The first is, what kind of reports can be generated here? And along with that, what are the reports specific to study care gaps?
Ed, I'm going to let you grab that one.
So what we have been doing is customizing the reports based on essentially filling in the gaps for reporting that doesn't exist for clients now. And we have, as we've shown you, essentially a largely complete clinical picture of the patient. So any of like the G-Pro measures, if you're Medicare ACO or if you're in a commercial program, HEDIS measures can be calculated with the data that we have available. Likewise, lots of different metrics around ADTs and hospital and ER utilization can be calculated relatively easily. But the tact we've been taking now, so that we're not reinventing the wheel for people, is that if somebody already has an analytics tool, we're filling in the gap and providing a variety of different reports that may be more beneficial directly, let's say at the practice level, or filling in reporting gaps at the ACO level. Because one thing we've noticed is an ACO may have very strong reporting capabilities, but that data doesn't necessarily flow down to the practices in as timely of a manner, maybe as needed for a practice to intervene and affect those numbers quickly. So that's kind of the methodology we have around reporting right now, because we wanted, like I said, to avoid reinventing the wheel for clients that already have strong reporting capabilities.
Great. And the next question, which is actually going to be the last one we have time for, we actually did have some more. Unfortunately, we won't have time, but this is a quick question. It says the patient can send chat messages directly to their provider. Is this correct?
I'll take that one. At this time, the way it's set up, we did not turn that on, mostly because, well, essentially provider feedback at this point. It's something that can be enabled for someone that wants it, but the default setup is to allow messaging between care team members, but not necessarily from the patient back to the provider. But that's something that can be enabled quickly for someone that would desire to have the patient more communicate with them through this application.
Okay, very good. Well, unfortunately, everybody, we did have some extra questions, but we are out of time for our allotted time slot today. But that doesn't mean that we will not answer your questions. So they are submitted, and we have that, and so we'll make sure to get back to you and answer those. As we conclude, I wanted to let you all know that we are having an interactive roundtable discussion as a follow-up to this discussion, and we wanted to involve you all. And this will be a little bit more of an interactive setting. And what I put in the chat earlier is a link to actually register for that. If you would like to do that, it only takes about 10 seconds to register. And there's a place where you can actually request if you have any specific topics you would like covered. I will also be sending out the slides and the recording afterwards, and it'll have a link to registration there as well. But we'd love to see you. It's on December 10th, 11 a.m. Central, 12 p.m. Eastern. So thank you again to our presenters. This was very informative. We covered a lot. I wanted to encourage you all before we close out to stop by the ACOexhibithall.com and visit the eMed Apps booth there. It's an interactive virtual exhibit hall, and the eMed Apps is really cool. You can go in and interact with their team there and learn a little bit more about them and connect with them there. And this is a little image of what that looks like. So head on over to ACOexhibithall.com. That's also where you'll be able to find the recording in the archive library there. So I hope that you join us over there as well. And thank you all again for attending. I know this is busy times. We all have a lot to do and a lot on our plates. So thank you so much for giving us the time. And if you would like to reach out to any of our speakers directly to ask them any questions or connect with them, you can, this email is what you would want to use, info@emedapps.com, and one of them will get back to you soon. So thank you all again so much for joining. Be safe. Happy holidays, and we will talk to you again soon. Hope to see you at the roundtable discussion. Bye-bye.